So, good evening, friends. I welcome you all for this Secret of Neurology Knowledge Feast for All Neurologists, episode 22. And today we are having a team from Krishna Hospital, Karamsad, Gujarat. And I welcome you all for this Secret of Neurology. The session will start from 8 o'clock and we'll try to end it up by 9:30. So it's an immense pleasure to welcome Dr. Sudhir Shah sir, who is our course director. Dr. Sudhir Shah sir is a professor and head of department, NHL, MMC, and SVP, IMSR, Ahmedabad, and director of neurosciences, Sterling Hospital, Ahmedabad. As sir is having professor and HOD and consultant neurologist of HE, the governor of Honorable, that is Governor of Gujarat, and past executive committee member at the Indian Academy of Neurology and advisor to the World Yoga Foundation. Sir is having a lot of chapter and publication, authors of 6 books on neurology, public education, and several states, as well as the national international journals. And further to this, sir is having a lot of achievements, awards, and sir is having confirmed and the most prestigious, that is a Padma Shri award. And sir is having Dr. DC Roy award, that is in 2018. And sir has got FAAN USA and FRCP, that is London, and recipient of UNO award, the Global Visionary Award. And the interest of sir is having the interest in stroke, neurodegenerative diseases, and epilepsy. I welcome you, sir. And further to this, I welcome Dr. Lakshmi Narasimhan, sir. He is our course director, the director and professor, Institute of Neurology, Madras Medical College, Chennai. Sir is having a lot of award and affiliations, as sir is having a Palliative advisor from N 2007, that is 2007, and sir is A.B. Baker's Award for Global Best Teacher of American Academy of Neurology, and sir has got the Best Paper Award of American Academy of Neurology and American Indian Neurologist Association 2009, and sir has got the Global Elsevier Atlas Award winner again in August 2015, and sir is having the executive member, World Federation of Neurology, and sir is having a lot of publication committee of the World Federation of Neurology. And further this, in the especially as well as the contribution of sir in neurosciences, he is 3-term executive member in the Indian Academy of Neurology and CME convener and of Indian Academy of Neurology. Sir has successfully organized 7 consecutive clinical neurosciences program for all India DM postgraduates, with the name of SHINE. There's a specialized, highly intensive neurology education that is from 2010 to 2017. Welcome you, sir, for this Secret of Neurology. That is a session 22 is there, sir. Over to Dr. Sudhir Shah, sir.
Thank you, Mr. Chadda, for this nice introduction of all course directors. Let me take this opportunity to thank all the audience, wonderful audience who has given tremendous support and interest in all our webinars. I think this is 22nd consecutive monthly webinar, that is Secrets of Neurology, Knowledge Feast for All Neurologists, Pulse of Wisdom. That series has been one of the most successful teaching series for juniors and seniors alike. Basically, this was designed for DMDNB students, but over the time soon became popular among the practicing neurologists, not only in India, but across the globe. And I'm very happy to announce that we received communications and thanks and appreciation from USA, UK, Spain, Germany, Mauritius, Thailand, Sri Lanka, and so many other distant places, let alone India. So I really congratulate all the previous mentors of webinars and those students who participated. And in the same vein, today we have one more wonderful webinar from uh, uh, my friend Dr. Soham Desai from Pramukh Swami Karamsad Medical College, that is Anand Karamsad. Now, I must also not forget to thank Globusel Division of Intas Pharma, and which is headed by Mr. Chadda and supported by Dr. Haley and Manoj Kumar and other team members. So for their logistic support and networking. Without their efforts, this would not have been so successful. I must also compliment and thank my colleague, Dr. Lakshmi Harsian, for, I would say, untiring efforts and tremendous zeal in making this program so successful. Dr. Lakshmi is a kind-hearted, nice gentleman, very amicable, polite, and loaded with profound knowledge. And one has to learn so many qualities from him. With that brief note, I would introduce the speakers for today. Dr. Arshad Chovatia is a senior resident at the Sri Krishna Hospital, Pramukh Swami Medical College, Bhaikaka University, Karamsad, who would do case presentation. Next slide, please. Dr. Tejaswini is a junior consultant, BRNB, from Narayan Hospital. She has joined Sri Krishna Hospital after passing, and she is a faculty there, and she would be doing case analysis and some further insight to the case. Next slide, please. As usual, then we will have little senior neurologist. Here we have Dr. Mihir Parekh, who would do differential diagnosis approach and dissection of the case. As you know, Mihir is also a very prominent upcoming name. He is practicing at Baroda and he is MD Medicine, DRB Neurology, and he has done fellowship in epilepsy at KIMS Hyderabad under Dr. Sita Jayalakshmi. He has 10 publications in peer-reviewed journals and international and national journals. His interest is epilepsy, and he is, it is a matter of pride that Gujarat is also now a epileptologist, and this is one emerging one. So Dr. Mihir is also doing private practice, but attached to Sri Krishna Hospital, Pramukh Swami Medical College as a visiting consultant, and I'm sure he will give wonderful insight to the case. And the mentor for all them is my friend, a very well-known neurologist from Gujarat, and a good academician, a very prominent clinician, an author, reader, and a wonderful personality. Hello. So he is also attached to Sri Krishna Hospital, Pramukh Swami University. He is professor and head neurology senior consultant. He is editor, AIN Journal and Annals of Movement Disorder Journal. is a EC member of Movement Disorder Society of India, is a member of so many august bodies like IAN, IESA, WFN, WSO, etc. He has to his credit more than 50 peer-reviewed publications. He has 20 plus book chapters and more than 50 citations with the good H index of over 13, etc. So his major achievements are he has at a very young age he received Sorayano Award at WSC Montreal 2018, WSO Young Scientist Research Fellowship at UMass One Center Boston in 2017, IAN Travel Fellowship in 2017, WFN Research Grant Award 2019. He has under him DNB course at Karamsad, that is near Anand. So with this, I think I would like to hand over mic to Dr. Soham Desai to conduct today's Secrets of Neurology. I'm sure he will bring out something extraordinary, whether from the diagnostic pitfall side or from the approach point of view or from the differential diagnosis or in the management, because he's such an inquisitive brain who would really give a lot of thought to each patient he sees with all great details. So Dr. Soham, please take over.
Thank you, Dr. Shah. And I think what he said is correct, but actually there's a dictum that like Kaplan used to say that you learn neurology stroke by stroke, but that is because strokeologists love stroke, they say like that. But I think each neurology patient, I would like say we can say even each medicine patient, you can learn something or other. I think each patient will have some story, and if we spend a lot of time with them, there will be a lot of things to learn. And I think medical colleges across India, I think they are like museums, I say, because they each of them have such lovely cases that we require actually the brain, the eyes to see. That we need eyes will only see what our brain knows. So sometimes such stories are good to discuss. I think a lot of times in forums, what happens is that you discuss case over 5 minutes, 10 minutes. But the best thing about the session here we have by Dr. Lakshmi and Dr. Shah is that each case is discussed at length, like at around 1.5 hours to spend on a case is very good. I think so. Let's without wasting much time, I'll not speak much. Let my members and colleagues speak more about the case. So first, Dr. Harshad, I'll welcome him. If the technical glitches are sorted out and he can share his screen, so he'll present the case. Then Dr. Tejaswini will talk about reasoning clinically. Then Dr. Mihir will show the investigation and reveal the diagnosis. And I may just contemplate a few things on the case at the end. Thank you. So, Dr. Harshad, can you join now?
Yes, sir.
And please share your slides.
Sorry for the technical issue.
It's okay. And in case you can stop your video if the clarity or net goes away and you can speak. Yeah. Please share this. Thank you.
So you want me to share your slides?
Yes.
You'll have to put a slideshow. Yes. Okay.
Thank you for the kind of introduction. I am starting my case. An interesting case, a middle-aged female with diplopia, seizure, and forehead lumps. And next, a 38-year-old female present with headache since 12 weeks, left scalp lump since 10 weeks, subcutaneous lump since 8 weeks, and dry cough since 6 weeks. Drooping of left eyelid with double vision since 4 weeks, and 2 episodes of seizure since 2 weeks back. Now the description of headache. Duration is 12 weeks, onset is subacute, and localized over the left scalp, anterior aspect of forehead, and characteristic of dull aching. Initially is a mild severity, VAS score is a 4/10, and then gradually increase in severity. VAS score is a 7/10, continues throughout the day. And negative is no issue of any associated with nausea, vomiting, no issue of postural diarrhea and variation with headache, visual or sensory aura, photophobia, phonophobia, no issue of lacrimal rhinorrhea or no specific trigger noted, and no tinnitus or vertigo. Now, second is a left scalp lump, developed 2 weeks after the headache, and location was over anterior aspect of left forehead. Size is initially small, around peanut size, and gradually increasing size is a lemon size, and associated with pain and tenderness, redness. And there is no issue of any ulceration or discharge from the lump, no tingling sensation over the scalp, no pigmentation over the lump, and no issue of trauma. Now, other subcutaneous lump, after the 4 week of headache, she noticed 2 lumps by only self palpation, not visible. First is over the left thigh, which was, and second is over the abdomen, just above the umbilicus. And after 6 weeks of headache, she developed the dry cough, increasing severity gradually. Cough is not any postural diarrheal variation or not associated with expectoration, hemoptysis, or not associated with chest pain, breathlessness, or throat pain. Now, after 8 weeks of the headache, patient developed the drooping of left eye, which gradually increasing swelling and redness over the left eye. And this drooping of eyelid is not any fatigability or fluctuation, no any issue of redness in eye, no increase in forehead wrinkles. And associated with drooping of eyelid or partial ptosis, patient develop binocular diplopia and resolve when one eye is occluded, only on looking on left side and on distance vision. Image was separately horizontally with far vision, far image is blurred and near image is clear. No any diurnal variation of diplopia symptoms, no any history of fatigability. Then after 10 weeks of headache, she had 2 episodes of seizure. Seizure started from right upper lip tonic posture, followed by violated tonic-clonic movement, uprolling of hair, frothing from mouth, and LOC with mild postictal confusion, lasted for 1 to 2 minutes. And a similar second episode without regaining normal state of consciousness in between. And there is no any previous history of aura like visual, sensory, auditory, or no automatism. This during the course of illness, she felt another subcutaneous lump in left arm, right thigh, and left popliteal fossa. All swelling are painless, mobile, and no redness, ulcer, or discharge over the swelling, and not interfering with movement. Now, negative issue of general, there is no issue of forgetfulness, altered behavior, no issue of vision, vision loss, deviation of angle of mouth, facial tingling or numbness, and no issue of vertigo, tinnitus, hearing impairment, or difficulty in swallowing and speaking. We should rule out the higher mental function and cranial nerve involvement. Then there's no issue of weakness in any 4 limbs or no issue of tingling, numbness. Describe the motor systems. Rule out. No issue of excessive sweating, no issue of urinary or stool incontinence, and postural dizziness or dryness of skin, gait instability or involuntary movement, and fatigable weakness. There is systemic, there is no issue of weight loss, loss of appetite, night sweat, evening rise in temperature, and chronic diarrhea or fatigue. Also, there is no issue of chronic joint pain, photosensitivity, skin rashes, oral ulcer, genital ulcer, and no issue of any redness of eye, eye discharge, dry eyes, dry mouth, nasal mask, nasal discharge, or nasal bleeding to rule out connective tissue disorders. Then a drug is during the course of illness, short course of steroid was given, which was after that the patient is improving my cough and decreased forehead lump size, but again started symptom and again new symptoms and new lumps are appear. Family and past is not significant. Now this disease course, 12-week patient had developed a headache, and after 2 weeks left side scalp lump, then after 2 weeks subcutaneous lump in abdomen, thigh, forearm, and back of knees, and after 6 weeks developed the dry cough, and then after 8 week left eye ptosis, diplopia, and after 2 weeks developed as a seizure. So summary is a young female with subacute onset and gradually progressive left side headache with scalp lump and other subcutaneous lump with left eye partial ptosis and diplopia with left lateral gaze and with seizure and dry cough with minimal improvement with steroid. Now the examination part, general examination. In the left forehead lump with eyelid swelling and partially ptosis. Left eyeball is placed medially. And now the detailed examination of lumps, forehead lumps. Inspection location is left forehead and frontal region of scalp. Size is a lemon size. Shape is spherical. Redness is present and no discharge or visible pulsation. In palpation, size of 5 to 6 centimeter. Spherical in shape and bony hard consistency. Tenderness present over the swelling. Fixed to the underlying bone and warm to touch. And overlying skin of the lump is not moving, doesn't appear to fix to the lump, and tense and taut over the swelling. No pulsation felt, and no fluid release on percussion and auscultation is no fluid on. Other lump that are not visible on inspection or only by felt palpation. Its size is all around 2 to 3 centimeter. All are spherical in shape and thin consistency. It's not fixed to underlying structure. All are mobile and not tenderness or discharge. Or skin is purely mobile over the lump. There is no palpable axillary or cervical lymph node, no skin rashes or ulcer over the skin. This is a general examination. Left side scalp lump with tense skin and mild redness with left eye partial ptosis and eyeball is placed medially and inferiorly. Now CNS examination. Patient is conscious oriented and time-period person oriented and environmental function and speech was normal. In cranial nerve examination, vision and visual field are normal. Pupil is bilateral reactive to light. Direct and indirect light reflex is present. No RFPD. Extraocular examination. This is the video. Just play. This examination of 7th now. There is a noise examination of the 7 now involvement. Extraocular movement. And decrease the restriction of left lateral position, left lateral gaze, and a mild restriction on upward movement also present. Examinations of the left rest cranial nerve examination are normal. Motor examination, sensory examination, cerebellar and extrapyramidal gait examination all are normal. Now the final summary after the clinical history and clinical examination. Young female with subacute onset and gradually progressive. Left side headache with a lump on the left forehead and other subcutaneous lumps in other part of body with left eye partial ptosis and left 6 nerve palsy associated with seizure and dry cough with partial improvement with steroid. And then so now localization is done by Dr. Tejaswini.
Okay. So can you allow Dr. Tejaswini to share her slides, please?
Sir, she can share. Dr. Tej.
Yes. Please begin from the first slide, Tejaswini. Okay. So she will do a diagnostic reasoning and dissection of each and every symptom and give a differentials before so that we can proceed for the investigation later on. Dr. Tejaswini, you can begin.
Hello. Hello.
Yes, you are audible. Please make a slide.
Audible, ma'am. Yeah.
Yes. Good evening, everybody. I'm Dr. Tejaswini, and I will be speaking about the case of a middle-aged female with diplopia, seizures, and a forehead lump. And I will be speaking about the clinical approach, reasoning, and differentials. First, we'll start with the summary. So we have a 38-year-old female who presented with 3 months history of subacute onset localized headache in frontal region, followed sequentially by progressively enlarging scalp lump, left eye swelling, drooping of left eyelid, binocular diplopia, and left gaze with preserved visual acuity, followed by 2 episodes of focal to bilateral tonic-clonic seizures. Next slide. So during the evolution of the above symptoms, she also developed multiple lumps in left arm, right thigh, and left popliteal fossa, along with chronic dry cough. So here we are seeing that there are mainly 7 symptoms: headache, scalp lump, drooping of left lid, vision, focal to bilateral tonic-clonic seizures, multiple soft tissue swellings, and dry cough. So first we will be speaking about the headache. So headache in this case, it can be primary headache or secondary headache. So we feel that in this patient, it is more likely to be secondary headache. The reasons for which are the subacute onset, localized nature of the headache, progressive nature, that is the severity increases day by day, continuous aching type of headache. So all these features go in favor of secondary headache. What are the red flags for secondary headache? This is given by the American Headache Society, SNOOP 4. It includes if there is presence of systemic signs and symptoms, neurological symptoms and signs, suddenness of onset, older age at onset, that is more than 50 years, pattern change or progression, presentation by Valsalva manner, positional aggravation, or papillary edema. In this case, we have systemic symptoms and signs as later patient develops dry cough. We have neurological symptoms and signs as patient later develops seizure and double vision. And there is a pattern change and progression of the headache. So all these features are pointing towards a secondary headache. Then what are the pain sensitive structures which can cause headache? So we have intracranial pain sensitive structures and we have extracranial pain sensitive structures. Intracranial pain sensitive structures are arteries, medium-sized branches, dural arteries, large veins and dural venous sinuses, dura mater near the blood vessels, and recently found to have pia mater and small cerebral vessels are also pain sensitive structures. Extracranial are external carotid arteries and their branches, periosteum, fascia, scalp and neck muscles, skin and cutaneous nerves, cervical nerve and nerve roots, cranial nerves, mucus of sinuses and teeth. So all these are the pain sensitive structures which can cause headache. In this patient, our possible localization is most likely scalp structures because the headache is very localized and it is localized over left frontal region, and usually superficial structures will cause localized headache, whereas the deeper structures will cause more diffuse headache. So scalp structures like periosteum, superficial structures, and later extending intracranially is possibility. Possibility is inflammation secondary to infection or infiltration. And third possibility is a space of occupying lesion like meningioma, which is a dural lesion, which can cause mass externally in the scalp by hyperostosis, and it can also cause localized pain. So all these are the possible localizations for headache. The second symptom which we are going to analyze here is scalp lump. So in scalp swelling, we have benign scalp swelling and malignant scalp swelling. Benign scalp swelling, which we need to know are: one is epidermoid cyst, second is dermoid cyst, third is sebaceous cyst, melanocytic nevus, trichodermal, but the common ones which I am speaking about: sebaceous cyst, lipoma, neurofibroma or schwannoma. And among the malignant, we have squamous cell carcinoma, basal cell carcinoma, then malignant melanoma, lymphoma, and metastasis. So these are the different scalp swellings. Whenever we get a patient with scalp swelling, we need to consider these possibilities. In non-traumatic scalp swellings, we can divide, because in this patient, there is no history of trauma. So we have excluded subdural hematoma. We have excluded other causes like hematoma or superficial hematoma. So now we speak about non-traumatic skull swellings. They are round, well-defined margins, soft tissue infiltrating, and bone lesions. So round, well-defined margins are seen in case of mostly benign ones like dermoid cyst, epidermoid cyst, lipoma, slow flow vascular malformations. All this will have round, well-defined margins. Soft tissue infiltrating ones are plexiform neurofibroma, basal cell carcinoma, squamous cell carcinoma, and bony lesions are caused by Langerhans histiocytosis, intraosseous hemangioma, atypical malignant melanoma, lymphoma, and metastasis. These are the ones which are usually causing the bone lesions. So now we'll speak about the skull swelling localization, how we will analyze the symptoms and examine findings. So here the local tenderness, warmth, redness, and pain. All these features suggest ongoing inflammation. So we know that there is ongoing inflammation in the swelling. It is a single, progressively enlarging lesion on the scalp, which has well-defined margins. This goes in favor of either chronic inflammatory pathology or neoplastic etiology. Absence of discharge or induration goes against abscess, osteomyelitis, or cellulitis, which will usually have some discharge or induration. There are no observed or felt pulsations, which rules out any vascular source of the swelling or underlying vascular structure. Fixity to underlying bone and immobility of the swelling, it is a very important finding, which localizes to primary bone lesion, which later invades the skull, or intracranial swelling, like meningioma invading the skull and extending into the skull, or cutaneous or subcutaneous lesion infiltrating bone and local structures. So hard consistency and immobility, here the consistency is also hard. That goes in favor of either bony lesion or infiltrative lesion, or meningioma with hyperostosis. Unyielding nature rules out cystic swellings. Though it is not fixed to overlying skin, but rapid expansion has led to the skin over it being taut and immobile. But we don't think it is fixed to the skin or it is arising from the skin. Hence, our most likely localization in this case for the scalp swelling is bone. However, it could still be a lesion infiltrating the bone arising elsewhere. Given the bony hard consistency, clear margins, infiltrative lesions are less likely, and more likely it is a primary bone lesion invading the skull, and secondary dural involvement is most likely. So whether this is benign or malignant, there are points favoring benign etiology and points favoring malignant etiology in this case. There is no absence of constitutional symptoms like fever, weight loss, and night sweats. Surface is smooth. Well-defined margins are there. Absence of local palpable lymph nodes or secondary changes like ulceration, fungation, and the initial presentation with pain, which favors inflammatory pathology. So all these are the points favoring benign etiology. But why should we also consider malignant etiology in these cases? The rapid growth or expansion of the lesion, fixity to underlying structure, hard consistency, and later development of double vision, seizures, and simultaneous appearance of multiple swellings in other parts of the body, and later involvement of lung. All these things favor malignant etiology. So the most common differentials which we will consider at this point of stage is TB of scalp secondary to calvarial invasion or invasive fungal granulomas, inflammatory lesion like cutaneous sarcoidosis, skull bone metastasis from visceral primary like breast, lung, or prostate, lymphoma, marginal zone lymphoma, primary B-cell lymphoma, diffuse large B-cell lymphoma, and histiocytic disorders like Langerhans histiocytosis or Erdheim-Chester. Our third symptom which we are going to consider here is drooping of left eyelid. So this patient presented with drooping of left eyelid, which was also associated with mild restriction of elevation. First, we will think about, because levator palpebrae superior is supplied by the oculomotor nerve, we will think about the course of the oculomotor nerve. We have in oculomotor nerve, there are two unpaired nuclei, unpaired nucleus like Edinger-Westphal nucleus, which is for the pupils, and there is a levator palpebrae subnucleus, which is also unpaired nucleus. Rest of the nucleus are paired nucleus, and of that, the nucleus for superior rectus also innervates the contralateral side. So in these features, like if ptosis is unilateral, it is less likely to be a nuclear lesion, and elevation also, it will be affected bilaterally in case of nuclear lesion. Then along the course, we also have that in the circle of Willis, then it proceeds forward in the cavernous sinus, where it lies with the other cranial nerves, like cranial nerve, sixth cranial nerve, trigeminal nerve, and cranial nerve fourth, along with the ICA and sympathetic plexus. So here Horner syndrome can also be there. And then there is superior orbital fissure. There also it lies in relation to other cranial nerves supplying the extraocular muscles. And in some books, it is mentioned anterior part of cavernous sinus, in some books, superior orbital fissure, that it divides into two branches, superior and inferior division. So superior division is supplying the superior rectus and levator palpebrae superioris, and rest of the muscles supplied by the third nerve are supplied by inferior division of the third nerve. So this is taken from Brazos regarding the structure involved and the clinical manifestation. So in nuclear lesion, there is a complete cranial third palsy, contralateral ptosis, and superior rectus paresis. If it is a subnucleus involvement, it will be ipsilateral isolated muscle palsy, except in case of superior rectus, where it will be bilateral, and in case of levator palpebrae, in which there will be bilateral ptosis, levator subnucleus. Then it can also be fasciculus involvement that will be in multiple locations. It will cause different symptoms according to the nearby structures. Like if cerebellar peduncle is involved, Claude syndrome will be there. If cerebral peduncle is involved, Weber syndrome will be there with contralateral heavy paresis. And if there is involvement of red nucleus or substantia nigra, there will be contralateral coriform movements, which is known as Benedict syndrome. Then it can also be involved in though the divisions are forming from cavernous sinus, but topographically, sometimes superior or inferior division palsy can occur in the subarachnoid space. In the cavernous sinus, it can occur with or without other cranial nerve involvement. Similarly, superior orbital fissure, which we have already discussed. In orbit, especially, there will be either visual loss or proptosis or swelling of lids or chemosis, and there can be branch involvement. So here, because of the left eye swelling and ptosis, swelling can suggest two possibilities. Either that the primary lesion is extending to the cavernous sinus and orbit, or there is a development of new lesion in the orbit. Now, unilateral ptosis with restricted upward movement, eyelid swelling, and absence of pupillary involvement or other extraocular movement involvement of other extraocular movement of third nerve involvement is likely to be isolated superior division of third nerve involvement. So isolated superior division will most likely localize to the orbit, but it can also include anterior cavernous sinus or superior orbital fissure. But most likely, given the eyelid swelling and other features, will most likely consider that orbit is the localization here. Then next symptom is double vision. So if we see the double vision, it can be monocular or binocular. What we have here is binocular. Monocular will persist in spite of covering one eye. This happens in case of ophthalmological disease or visual cortex involvement or any psychiatric conditions. Binocular diplopia can be because of mechanical entrapment of the muscles, or it can be because of muscle pathology like thyroid myositis or orbital myositis. Neuromuscular junction can also cause binocular diplopia. However, in this case, we don't feel it is there because there is no history of fatigability, there is no fluctuation, so neuromuscular junction is excluded. And last one is cranial of third, fourth, sixth, and the central pathway involvement can cause binocular diplopia. In this case, we will look about the characteristic of diplopia. It developed late in the course of the illness. There is horizontal diplopia, and two images are separated horizontally. It is worse for far objects and it is worse for left lateral gaze. And there is esotropia of the left eye in primary position and abduction restriction of the left eye. All this favor that there is a left sixth nerve involvement or mechanical restriction of lateral rectus in the orbit. These are the two possibilities. This is the abducens nerve course. So it starts in the pons. We have the nucleus. Nuclear lesion will cause gaze palsy. So I don't think this is a nuclear lesion. And then from the clivus, it will turn. There's a long course, and then it can also be involved at the petrous apex and cause Gradeniger syndrome. Then in cavernous sinus also it can be involved, where it is lying with other cranial nerves and superior orbital fissure and orbit. So these are the places where the abducens nerve lesion can be there. And along with that, because of a long intracranial course, it also can be affected due to raised intracranial pressure. So this is basically which are the various syndromes affecting the abducens nerve at the nuclear level, at the fascicle level. In the paramedial pons, it can cause Millard-Gubler syndrome, prepontine cistern, petrous apex, there will be deafness, facial pain. Cavernous sinus, there can be cranial nerve 6+ Horner syndrome or multiple cranial nerve involvement, superior orbital fissure, and orbit. So these are the different points where the abducens nerve can be involved. So diplopia localization, we have kept 3 localization. Either it is secondary to raised intracranial pressure, orbital infiltration hampering the lateral rectus muscle movement, and involvement at the especially in the presence of eyelid swelling, and other possibility are superior orbital fissure or anterior cavernous sinus. So after this, we come to the next symptom, which is focal to bilateral tonic-clonic seizures. So here, the seizure suggests that there is involvement of brain parenchyma. Either it could be symptomatic secondary to systemic causes, or there could be a primary lesion in the brain. Right upper limb tonic posturing followed by bilateral tonic-clonic movements localizes to focal pathology in the left hemispheric onset, most likely extratemporal epilepsy. So in other system involvement, we have presence of firm, painless subcutaneous swelling, which are freely moving under the skin, not adherent to underlying tissues and not adherent to the overlying skin, which goes in favor of subcutaneous granuloma, lymphoma, Langerhans histiocytosis, or other metastatic lesions, which we will consider here. And there is also history of chronic dry cough for 1 month prior to presentation. So we'll again in detail see the multiple soft tissue swellings. So soft tissue swellings, 2020 WHO classification. These are the main categories into which they are grouped: adipocytic tumors, fibroblastic or myofibroblastic tumors, vascular tumors, smooth muscle tumors, skeletal muscle tumors, peripheral nerve sheath tumors, and tumors of uncertain differentiation. And soft tissue masses can arise from the cutaneous, subcutaneous, fascia overlying the muscle, and deep tissue. Here in cutaneous, the important ones are carcinoma, myeloma, myxoma, and lymphoma. In subcutaneous, the important ones are myeloma, lymphoma, melanoma, epithelioid sarcoma, cellulitis, adenitis, abscess, and fascia overlying the muscle can be nodular fasciitis, fibromatosis, or fasciitis. Other way to classify is mesenchymal, skin appendage, metastatic tumor or tumor-like, and inflammatory. So mesenchymal can be lipoma, angioma, peripheral nerve sheath tumor, liposarcoma, leiomyosarcoma. Metastatic can be melanoma and myeloma. Tumor and tumor-like lesion can be myxoma, lymphoma, Darrier-Roussey subcutaneous sarcoidosis, granuloma annulare, and inflammatory can be cellulitis, adenitis, and abscess. So anatomical localization, considering the whole cluster of symptoms and chronological evolution with the systemic symptoms, the likely localization is one bony or subcutaneous scalp lesion eroding the skull and infiltrating the left frontal lobe and orbit, with or two or more separate lesions in the skull, left frontal lobe, and orbit, along with multiple subcutaneous lesions in different areas of the body and lung involvement due to the development of dry cough. So the possible etiologies can be lumped into four major categories: chronic infective like fungal, mycobacterial, or others; chronic inflammatory like sarcoidosis or autoimmune etiology; neoplastic like lymphoma, multiple myeloma, or secondary metastasis; or histiocytic disorders like Langerhans histiocytosis and Erdheim-Chester disease. So tuberculosis, why we should consider tuberculosis first is because it is endemic in India. So it's important to always consider tuberculosis. It can present in various ways. And here the points which are favoring tuberculosis are dry stage, ICP features, seizures, cranial nerve involvement, dry cough, subcutaneous nodules. Scrofuloderma are described in TB, which are painless firm subcutaneous nodules. So in this patient also we are having painless firm subcutaneous nodules. But later they may show discharge. Discharge was not present in this patient, but this is a possibility. And points against our calvarial TB, which is presenting as mass lesion, is very rare. More often, TB can involve the bone, but it will cause osteomyelitis or abscess, which is fluctuant or fluid consistency. So this bony hard lesion goes against tuberculosis. However, it has been rarely described. Then we come to fungal granuloma. So why we should consider fungal granuloma? In this case is aggressive nature, the rapid progression, aggressive nature, involvement of parenchyma, orbital infiltration, lung involvement, subcutaneous painless nodules, local swelling has erythema, pain, warmth, suggesting inflammation, local inflammation. However, the points which are against are, one is absence of immunosuppressive state. Patient was not a known case of any immunosuppressed disorder, or she was not seropositive or anything, which will more likely favor fungal granuloma. And fungal etiology is seen more often in older patients. She was a middle-aged patient. And there are sinuses are clear. There is absence of nasal discharge. There is no nasal mass. So all these are against. And hematogenous osteomyelitis is found more often in children. And in adults, it is more likely contiguous spread. So there is no history of trauma. So fungal granuloma is point. Then we consider sarcoidosis. So in sarcoidosis, this should be destroyed here because middle-aged female age is fitting, and gender, it is more common in females, so gender is also fitting. Dry cough also favors sarcoidosis, and multiple painless subcutaneous tumors, Darrier-Roussy variant. So all these are the points in favor, and points against are rarity of reported osseous sarcoidosis, and that too, skull involvement is extremely rare. However, reports of lytic lesion with skull mass exist, so we need to consider this. Then multiple myeloma, very less likely in this case, because first of all, why we are considering it is because it can present with skull lesion, subcutaneous lesion, lung lesion, and CNS involvement. It has been described. However, points against are, one is scalp lump-like presentation, which is very atypical, and that too, bony hard scalp swelling is very rare. And CNS involvement happens in only 1%, absence of constitutional symptoms, and most important is the age doesn't fit. It's usually seen in elderly patients. Neoplastic lesion like metastasis or lymphoma, only point against that is absence of constitutional symptoms. It can explain the bone mass invading the dura. It can explain the cranial nerve involvement. It can explain the intra and extravarial extension and intervening skull bone destruction. It can explain the presence of cough and rapid progression. So metastatic lesion or lymphoma is a strong possibility here. Then histiocytic disorder. This is a very rare disorder, but these need to be considered because they can present with bone lump, and they can present with multiple subcutaneous lumps. Multi-system involvement is very common in these disorders. Usually in adults, it will present with skull or jaw tumor with the cranial nerve palsies, and dry cough with lung involvement is also seen. What are the points which are against are? It is more common. Langerhans histiocytosis is more common in children. However, it is a lesser known disease, so it has not been exactly studied. So it is present, sometimes it is found in adults, so it should be considered. And Erdem-Chester disease is more often seen in adults, but it is a non-Langerhans histiocytosis, and it does not involve the axial skeleton. It more likely involves the bones and juxta-articular region. So that are the points which are against histiocytic disorders. Based on the clinical presentation and available clinical data, I would consider the following as the most likely diagnosis. I'd like to keep neurosarcoidosis on the top because of the age and gender also is fitting, and the presentation is also fitting. Only point which is against is presentation as a bone lump, which is osseous sarcoidosis is a little bit rare. Langerhans histiocytosis or Erdem-Chester I will consider as second. And neoplastic lesion like lymphoma, carcinoma, bony subcutaneous and serous metastasis. If the primary is in lung, it will explain the dry cough. So this is neoplastic lesion is also a strong consideration here. Chronic infective, we should consider because infective causes are more common in our country. However, there are many points which are against it. Absence of constitutional symptoms is very important. Lack of an immunocompromised state, and the presentation is also atypical. So all this make it less likely. However, we would still consider it. So these are the four possibilities which we will consider after the analyzing the clinical history and the available clinical data. Thank you. Now,
Thank you,
Dr.
Dr.
Mihir
Tejaswini. Thank you. I think she did a very reasonable dissection of each and every symptom, like as is the tradition in this series, and try to take up each and every symptom and go into detail and do a diagnostic scientific reasoning. And ultimately,
sir.
like for all infiltrated disorders, generally after clinicians see, generally the four things which always we consider are infective disorders, inflammatory non-infectious disorders, neoplastic disorders, and then rare other disorders with mixed pathology. So generally when we have this, I think generally these are the four common things that people will think when somebody has something which is going infiltrative along multiple parts of the body. So like, and what we'll think is that generally clinicians say that, okay, do the imaging. If required, CT scan, MRI, do a PET scan and get a biopsy done, and it is all over, I think. Generally that is the belief, and this looks like a clear-cut case, I think. And but in this case, despite the patient undergoing everything, there was no clue. So we'll come to that. What happened by the time the patient came to us, already all these things were already done. So Mihir will reveal what were the findings on imaging and biopsy already when the patient has come to us, and then we'll see how it went ahead. Are any comments or any other doubts allowed by the audience to write in the chat section. Directly, we can proceed to the investigations and discussion on that.
You are free to have interaction with the people if you wish,
So-
or
Okay. Or I think maybe people can write down in chat section if they have any comments further. But to not waste time, I invite Dr. Mihir to say what happened to the patient, or what was the story further, and what happened. Mihir, can you
I
share?
must- at this juncture, I must congratulate Tejaswini for very nicely discussing out differential possibilities, including etiology. So
Thank you, sir.
very nicely done, dear. Thank you.
Thank you so much.
So
Mihir.
good evening, everyone. So I will like to take the case further. How we approach the case with investigation, diagnosis, and further. So what Tejaswini has tell us, what we know till now. We have either bony or subcutaneous scalp lesion, which is eroding in the skull and infiltrating in the left frontal lobe and orbit, or there is two separate lesions in the scalp, left frontal lobe, and orbit. We have multiple subcutaneous lesions, and there is some lung involvement. So differentiation was first was non-infectious inflammatory pathology like sarcoidosis. Second was Langerhans histiocytosis or adult onset Erdheim Chester disease. Third was neoplastic lesion like lymphoma or carcinoma with metastasis. And fourth was chronic infection like tuberculosis or fungal granuloma. So let's see the investigations. So blood investigations, her total counts were persistently elevated. It were varying between 14,000 to 22,000. But smear was microcytic hypochromic. And ESR was also not much raised. And CRP was, it was 11 and 15 in 1 or 2 times. And otherwise it was less than 6 when the patient come to us. The rest of the reports were normal. The creatinine and total calcium were normal. Just because we kept a diagnosis of myeloma and differential diagnosis, the renal function and calcium were normal. Only positive finding was albumin was low compared in total protein. Her HIV was negative. RPR for syphilis was negative. ANA profile was negative. PN Skanka was negative. And S level was normal. So after 2 weeks of onset of symptoms, when she had only headache, she underwent outside MRI. This is the T2 axial sequence, which is showing some hyperintensity in the left high frontal region. It is just near a bone. But if you see the orbits and temporals, they are normal. Even the sinus looks normal. The flare sequence, it is also showing hyperintensity in the same region where we are seeing T2 hyperintensity in the left high frontal region. Here also we can see orbits and other structures are normal. So the patient underwent CT scan at that time. It is showing a lytic bone lesion, which is eroding the outer table of the skull. It is in the left high frontal region. Now, 5 weeks after onset of the symptoms, when she had a bit of forehead swelling, she underwent one more MRI. So first image is on the left side, it is showing same as hyperintensity in the left high frontal region. But what new finding which are seeing on the right side is there is some dural thickening in the left frontal region with some heterogeneous hyperintensity involving left inferior frontal region. This is the similar T2 image. If you are going lower side, there is a dural thickening with hyperintensity. But at this junction also, if you see sinuses and orbits are normal. This is the flare images, coronal section, which is showing hyperintensity in the inferior frontal region. And this is a diffusion, which is showing some amount of restriction without ADC reversal, and there was no blooming on GRE. So at the 5 weeks of onset, the patient has left high parietal hyperintensity, but what new thing was there is some dural enhanced, there is a dural thickening with possibly vasogenic edema in the left inferior frontal region. Now, how we have to approach this? What finding we got is lytic bone lesions. So can it help in narrow down our differential diagnosis? So predominantly there are 3 major causes of lytic bone lesions. It can be normal variants, it can be inflammatory lesions, or it can be neoplastic lesions. So if we see normal variants, is very known, arachnoid granulations are known to cause lytic bone lesions, but they are generally seen in the parasagittal region, most commonly the suprasagittal sinus or transverse sinus distribution. If we see inflammatory cause, then most common cause is eosinophilic granuloma. Basically, it is localized variant of Langerhans histiocytosis. It is commonly caused erosion of the inner table of the skull, and it will cause round-like single lesion, and counts will show elevation of the eosinophils, which was not in our case. If we see, because we have capitalized sarcoidosis, there are very rare case reports of lytic bone lesions. This I could found of a 29-year-old female in which with sarcoidosis there was invasive involvement of the arch of atlas and also in the cleavus involvement. So, but sarcoidosis definitely very rarely cause lytic bone lesions. Now coming to infections, as we know, invasive fungal also can cause involvement of bone and lysis and also tuberculosis. There are many cases of involvement of bone. Now coming to benign neoplastic lesions. Most common is aneurysmal bone cyst, but generally most commonly they are associated with other bone tumors like giant cell tumors or sarcoma. Epidermoid cyst, which is most commonly located in the frontal, parietal or occipital region. It is also benign lesion, which is likely to cause lytic bone lesions, like in this slide. Now coming to multiple myeloma. Multiple myeloma will cause well-defined round lesions, and they will be multiple, which is not in our case. Even the blood investigation also not favoring of multiple myeloma. Lymphoma generally will cause destructive lytic bone lesions. It will be very wide-spreading lesion. Metastasis, if we see, most common renal metastasis, followed by myeloma, then multiple myeloma, then non-small cell lung cancer, thyroid cancer, non-Hodgkin's lymphoma, and Langerhans histiocytosis. This metastasis were predominantly lytic, and metastasis will involve generally both inner and outer table of the skulls, and they will be also destructive. But generally, what they say, lesions will be very defined by margins if it is metastasis. Now coming to Langerhans histiocytosis. So there are many case reports, but if we see children, then most common site is calvarium for lytic bone lesion in Langerhans histiocytosis. But if we see adults, it involves jaw first, which was not in our case. So before the patient came to us, by 12th week onset, she underwent third MRI. So by the time there are some obvious findings. What here we can see in T2 weighted axial images, there is a scalp swelling in the left frontal region, which is a hyperintense lesion. And if we go further, lesion is invading the skull. And after invading the skull and dura, it is penetrating the brain. So basically the lesion has started in the left scalp, it has infiltrated the bone, and it has involved the left inferior frontal lobe. And also if here we can see it has involved the lateral and superior part of the orbit. And if we see middle images, the eye globe is displaced medially by the lesion. In the last images also, if we can see, this is the old left high frontal region, which was seen in the first MRI. So by the 12 weeks, the lesion has expanded, it's infiltrated in the bone and inferior frontal lobe and orbital roof. This is the flare sequence, which is also showing the similarly hyperintense lesion in the left scalp frontal region with infiltration of the left inferior frontal lobe. But what we can see, the perilesional edema is very significant. It is also causing the midline shift of around 8 mm. Here we can see the involvement of the left superior and inferior rectus muscle and globe. This is the contrast sequence, which is in which we can see the soft tissue swelling is very nicely enhancing. But if we see inferior frontal lobe lesion, it is heterogeneously enhancing, plus involvement of the left eye globe. Plus one more thing, if we notice in this image, sinuses are clear. There is no involvement of any of the sinuses. This is the GRE sequence. It was showing no major blooming inside the lesion. So now just coming to one slide, how we differentiate different patterns of enhancement. If we see second slide, it is showing thick irregular periventricular enhancement, which is commonly seen in primary CNS lymphoma. Next is thin linear pattern of periventricular enhancement, which is seen in CMV, ependymitis, and encephalitis. Gyral enhancement, if we commonly see post-stroke or herpes simplex encephalitis. Leptomeningeal enhancement we see commonly in bacterial meningitis, which we can see in this 5th slide. Next slide is showing combined enhancement, means dura is also enhanced and pyometer also enhanced, which is commonly seen like in our case in TB, sarcoid, lymphoma, and metastatic lesion. In case of pachymeningitic enhancement, it will generally cause dural enhancement. And the causes will be like sometimes metastasis or intracranial hypotension. A dural based lesion like meningioma will cause dural tail with dural based enhancement. Metastasis will cause subcortical nodular enhancement. Next one is small ring enhancement, which is commonly seen in cerebritis or metastasis. Ring enhancement with mirror nodules, which is commonly seen in pilocytic astrocytoma or hemangioblastoma. As we all know, incomplete ring enhancement is commonly seen in demyelinating lesions like multiple sclerosis. Pyogenic abscess will cause generally smooth ring enhancement. Well, irregular thick ring enhancement is commonly seen in fungal abscess or glioblastoma. So this patient underwent further workup. This CT scan was taken when the symptom of onset was 4 weeks. It is showing one nodule in the lung in the right upper lobe, which we can see here in the arrow in both the windows. So next, the patient also underwent a PET scan just at 3 weeks of onset. So in the left side of slide, what we can see is 2 enhancing lesions, one in the right upper lobe and second one in the left upper lobe. Both were FDG-avid enhancing lesion. And the right side of image is showing in the left umbilical, near left umbilical abdominal wall, there is an enhancing lesion. In this slide, what we can see in the left thigh near gluteus region, also there was one subcutaneous enhancing lesion. And here at that time, patient was only having left frontal lytic bone lesion, so which was enhancing in the PET scan. So the final report of PET scan was what we could find was FDG-avid lesions, and the SUV max was varying from 9.1 to 3.7. It was maximum in right arm nodule and minimum in the left lung nodule. Now, first, what is FDG-avid lesions before interpreting this? So FDG-avid lesions means heightened glycolytic activity. Most likely cancer cells with faster metabolic rate, such as colorectal adenocarcinoma, are very FDG-avid. But still, there are few cancers like mucinous cancers, they can consume less glucose and therefore they can be less FDG-avid. However, inflammatory cells, they can also increase metabolic rate. So they can also be FDG-avid. But this was a case in lytic bone lesion, how FDG-avid lesions will help in differentiating myeloma versus metastasis. So if we see average SUV max, in myeloma it is only 1.6. It was very low, average SUV max of myeloma patients. But in case of lymphoma, it is very high. It is average 8.2. Like other cancer, it was varying from 7 to 5. So anyway, we were sure that it is not a myeloma. So if we see summary of these images, we have left high frontal lytic bone lesion initially, multiple soft tissue lesions, bilateral lung nodule, and what new finding we got was left frontal scalp lesion with infiltration to skull bone, followed by orbital roof and inferior frontal lobe with high enhanced dura. So differential diagnosis, now what we see, I would like to keep still Langerhans cell histiocytosis or earth-encrusted disease initially, or neoplastic lesions like lymphoma or carcinoma of metastasis initially. But if we see PET scan, there is no hilar adenopathy. So, and plus lytic bone lesions. So neuropsychosis was now very, very remote possibility. And similarly, tuberculosis and fungal granuloma also 3 months course and looking at the patient and other investigation, there were very less possibilities. So this patient underwent CT guided biopsy first at the 5 weeks of onset. It was taken from the right upper lobe. Unfortunately, CT biopsy, I don't have slides, but the report that initially was reported was organizing pneumonia. The slides what described was, it was showing mixture of inflammatory cell infiltrate comprised of lymphocytes, plasma cells, histiocytes, and neutrophils. So basically, this CT-guided biopsy was not much helpful in coming to the diagnosis. And what we were sure it is not an infective pathology. So before the patient came to us, she underwent one more biopsy at 6 weeks of onset. It was from left high frontal bone region. So I'm showing you the slide of the same. So the left side is a scanner view, and the right side is a low power cut view. This is this left frontal bone region biopsy. It is, if you see the darkish region, it is showing some infiltration inside the bone. And what I'm showing you is a epidermal lining. So what was important is this high power view. So high power view, the findings were, this was one spindle cells, which are normally seen. Next was round nucleus, which is commonly seen in lymphocytes. And next finding was large cells, which large cell with mononuclear nuclei. And what additional finding, what we were seeing is there is this round nuclei surrounding the blood vessels, which is commonly seen in inflammation. So basically, this patient, by the time they came to us with the biopsy, this biopsy was also reported as bony fragment and fibroconnective tissue, showing moderate active chronic inflammatory cells with increased vascularity. So it was also reported as active chronic inflammation with granulation tissue in keeping with inflammatory lesions, and there was no evidence of malignancy.
Mihir, can you hold on for a few minutes here?
Yes, sir. Yes, sir.
Yeah. So this is the story till the and please keep that slide. I don't. So this was the story till the patient came to us. So by that time, around already 2.5 to 3 months had been spent. Patient had undergone, I think, multiple investigations, CT, MRI, about 4 or 5 times, a PET scan, one biopsy from the lung, and then biopsy from the frontal bone. And again, these were reviewed at 2-3 places, and it was all showing inflammation. Patient was also advised to take antibiotics, which the patient had taken injectable for 2-3 weeks, but no improvement. Was told to take tubercular drugs and steroids, but she couldn't tolerate it. And I think for after 3-4 days only, patient stopped taking tuberculosis medicine and then landed up with us. So as we were saying, when we do a diagnostic reasoning, and it sometimes becomes like a textbook picture, we think it is very easy. But when in real world settings, these are the problems we can face. So can we have some quick comments now what to do? Now we were telling the patient that you will need one more biopsy, either from the frontal bone or from the brain frontal lesion. Orbit was absolutely difficult to touch out. But the patient was actually exhausted from the finances also, and were not ready for any other third invasive surgery. So how do we proceed now?
Yeah.
You can quickly comment, or for lack of time, we can move ahead.
We could have with a little more advanced histopathology reviews, more detailed histopathology studies with more stains, and I think biopsy is the crux, and somewhere something is missing. So radiology has given enough guidelines, so maybe you are
Exactly, sir. So what we did is that we told the patient to get the blocks from the previous hospitals, and I think here lot of times general pathology may not just help. We need immunohistochemistry and cytogenetics.
yes,
A lot of time. So Mihir, you can proceed. What happened and review what happened ultimately.
Yeah. Okay. Okay. So now what to do? Repeat biopsy or IHC? So basically, we send the immunohistochemistry block to Tata Hospital, Bombay. So this was the report. Basically, in this slide, first left side B slide, what we are seeing is CD30 positive cells. So which and right side again, the right side is ALK positive cells. So
B cells, yeah.
Basically, these were the large cells which were reported earlier. They were tumor cells, and these large cells were showing CD30 and ALK as a positive immunohistochemistry marker. So This was the final biopsy report. It was a ALK positive anaplastic large cell lymphoma, which contains both IHC, CD30, and ALK. So now just quickly, I would like to review some of the literature of the ALK positive lymphoma. So what is ALK positive lymphoma? Basically, it's a anaplastic lymphoma kinase positive lymphoma. ALK means anaplastic lymphoma kinase. So if we see lymphoma, 10% are Hodgkin's and 90, most of those are non-Hodgkin's. In non-Hodgkin's also 80% are beta cell, and T cells are very less, they are 20%. And if we see NHL, it is just 3% of overall newly diagnosed cancer. So our patient has T cell NHL, which is also not common. And now in T cell AHL, if we see anaplastic large cell lymphoma, basically they are CD30 positive mature T cell lymphoma. And there are 4 types of it. 2 are systemic and 2 are localized. Systemics are ALK positive and ALK negative. And localized are primary cutaneous and breast implant associated ALCL. So basically, it comprised of 1 to 3% of adult and 10 to 20% of pediatric NHL. So our patient was 38-year-old. So it is not very common in adult group. And it is 2.44% of NHL in Indian studies. It is comprised of 15% of all T cell lymphoma. And incidence is 0.25 per 1 lakh cases. There is bimodal age of incidence. First peak in preteen and adolescent years, and second peak is in after age of 60 years. Our patient was 38 years. ALK in like lymphoma in older adults usually ALK negative. Now Indian studies. If we see Indian studies on T cell non-Hodgkin's lymphoma, in India most common subtype is precursor T cell NH. The second most common is precursor T cell not otherwise specified. But in India, third most common T cell lymphoma is ALK positive anaplastic large cell lymphoma. It is 15% of all T cell NHL. Now, what happens in ALK positive lymphoma? Basically, there is a ALK is the protein product of ALK gene normally located on the chromosomal 2. And ALK positive lymphoma, this rearrangement of the gene, most commonly on chromosome 5, but there are many other variants also. So there is ALK gene translocation, ALK protein overexpression because of this, and CD30 expression. So in this IHC will show CD30 positive because it's T cell anaplastic lymphoma. Next will be ALK positive, and third will be EMA, epithelial membrane antigen positivity. The hallmark of this should be histopathology, eccentric kidney or horseshoe-shaped nucleus with prominent eosinophilic perinuclear clearing corresponding to a Golgi area, which we can see clearly in these images. The clinical feature, it is more commonly seen in younger people and males. It presents as lymphadenopathy. In systemic symptoms as fever, excessive sweating, and weight loss. If we see extranodal involvement, skin is involved in 26% patient, bone 14%, soft tissue 15%, lung 12%, and liver is involved in 8% cases. However, CNS involvement is extremely rare in these patients. They generally occurs in younger age of onset, considered to have high risk disease. But in ALK positive lymphoma, because they occur in younger patients, they can achieve complete remission after chemoradiotherapy in a significant percentage of cases. This was a case report was reported in Indian Journal of Cancer, in which there is a sinonodal mass which infiltrates the orbit and it can present as pseudoproptosis, similarly to our case, but only thing sinus involvement was not there in our case. Now coming to treatment, there are 2 first-line therapy. One is CHOP and one is CHOP and DAPO. In younger patient, they say we should use cyclophosphamide, oxorubicin, etoposide, vincristine, and prednisolone. But in case of older patient, they don't use etoposide because of more side effects. But recently, recently what changed is that there is development of CD30-directed antibody, which is brentuximab. So BV plus CHP, which involves doxorubicin, prednisolone, and cyclophosphamide, is currently most of the centers the drug of choice because etoposide side effects are less with this regimen. In this literature, it was published in 2019. They have compared this both first line, in which if we can see progression-free survival with BV plus CHP chemotherapy, it is 68%, while it was 56% with CHOP chemotherapy. A second line therapy is targeted therapy, which is crizotinib. It is an ALK inhibitor. In clinical trials, it has shown excellent results, notably in juvenile population. They say radiotherapy is not much useful unless patient is not tolerating chemotherapy. And last is autologous hematopoietic stem cell transplantation for patients more than 40-year age, and if international prognostic index is more than 3, which involves patients' age, LDH level, and cancer stage. So prognosis, if we see ALK positive primary systematic lymphoma is better prognosis compared to ALK negative cases. So overall survival rate is 70% after 5 years. This is the recent follow-up of our patient. Our patient received CHOP chemotherapy, and this was around 1 week back. This is disappearance of the soft tissue lesions from the scalp, and she is doing well currently. Thank you.
Thank you, Dr. Mihir. Would you like to comment, Dr. Shah, or should I say a few words?
I would like to add. Sir,
yes.
Can I add a?
Yes, sir, Dr. Lakshmi.
Yes, sir. Sir, at the outset, thank you for a wonderful case. In fact, I was in any lesion with the lytic lesions to the bone, the differentials are all extraordinarily discussed beautifully by all your entire team. I first, my hearty congratulations for working up the case excellently. As Professor Sudhir Shah said, the catch was in the very good pathologist. The pathology and the immunochemistry, histochemistry backup is what was crucial in this case. And we had a similar case where patient presented with orbital lesions, lytic lesions in the skull, along with the involvement of the 3-4-6 cranial nerves and multiple lesions in the body. And then it ultimately turned out to be the Rosai-Dorfman's disease. Rosai-Dorfman's, as you all know, is one of the histiocytosis group of drugs, which what is important is the most important thing, even before the immunohistochemistry could be done, our neuropathology person picked up a phenomenon called emperipolysis. Emperipolysis is cell eating. You know, the one cell is completely engulfed by another cell, normally like phagocytosis. But what happens in phagocytosis, the cell gets killed. It doesn't remain intact inside the cell. So here, there are the different kinds of emperipolysis. I want the postgraduates to read about emperipolysis. There is the RBC emperipolysis, neutrophilic emperipolysis, lymphocytic emperipolysis, all those different kind of things. They all have very important pointer towards lymphoma. So the emperipolysis was picked up, and then that gave us a clue so that we proceeded on to the end. So this is almost a similar case which came to my mind. I thought I should share. My hearty congratulations to Soram and Desai and all the entire team from Karamsad Medical College. And we are all really thrilled. Thank you.
So may I add a few points here, like the first?
Yeah, please.
So yeah, like in neurology, we always say, like the traditional old neurology say that there are two ways to look at cases. One is apply the Occam's razor, and then other is that no, you apply the Hickham's dictum. So the Occam's razor says that always simple things are common, rare things are rare. So always think of common things first and try to apply your knowledge and rule out simple things. But like world is not so simple, and like especially medicine and neurology, with time, I think the way science is advancing, a lot of things are coming up with complex things. And so like the previously used to say that doctors used to say that when you hear the hoofbeats, just think of horses and not zebras. But sometimes like here, the biopsy always, because there were inflammatory infiltrate cells and large cells were seen, the general pathologist would generally report this as inflammation, as this was happening in the case of this patient. So sometimes, though the hoofbeats may be heard, it may not be horses, and unless we don't know or we don't go in detail, zebras at a distance may be thought of as black horses or black, some horse which are black and some are as white, and that can happen. And the other thing is that sometimes when we do this, like at the end in a reasoning session or when we present a case, I think what we do is we apply everything and like we write it down and do what we do is that this teaching reasoning. So a lot of times in practical life, this teaching reasoning and practically doing that reasoning when we are looking at the patient or when we are treating the patient initially, often that doesn't happen. So like we may take a shortcut, like take out a lesion, take out a biopsy and just get it done. And sometimes forget things like a plain biopsy is not enough. You need immunohistochemistry and now even cytogenetics for a lot of patients. What happened in this case. And a lot of times what happens, we start treating patients with symptomatic treatment. So like we give steroids, and lymphomas are such disorders that if you have a patient has received steroids, sometimes it can mask the features on biopsy. So the problem with India is a lot of time patients receive empiric therapy, sometimes just as a symptom therapy, just whenever somebody is swelling or cough something, steroids are just given rampantly. So that again leads to problems in the diagnosis. But important thing is that when the residents also look at each case, like they should look at it as if they would present it in front of somebody or in the exam. So in the exams, when the residents especially approach, they think that I know the diagnosis and the diagnosis is true. But as we are examiners, we generally don't look at whether they say one diagnosis. So people often jump onto giving etiologic diagnosis, TB or fungal or granuloma. So better way always we say is that look at what the symptoms are, do a reasoning and try to localize the symptom first, then make a syndrome out of it, and then think of etiology. Etiology generally on the basis of how it is progressing with time. That would give you a clue to the diagnosis in terms of etiology. But before that, I think localization is very important, as like we did. But I think daily in the OPD, when we see patients, we have to think in that manner. But sometimes in our busy OPDs, it is difficult to do, and that can lead to problems. And other problem is the healthcare is so rapidly expanding, the science is so rapidly expanding, but our systems in especially the low and middle income countries are still lagging behind. And the same way, even the patients or lay persons scientific acumen is not there. So I think as a doctor, I think we also need to spread awareness about medical science and its complexity. As Stephen Hawking said that we have to embrace complexity. So you know all Stephen Hawking, he suffered from motor neurosis, a big scientist. And he said that next generation medicine is the science of complexity. And the other thing is our science is now more and more about interactive work and teamwork. And like now cytogenetics, immunohistochemistry, personal medicine, using artificial intelligence in our diagnostic thing. I think those are the things like we will have to look into. And like getting diagnosis using your technology from remote places, like getting biopsy reviewed at higher center. I think that would be the way forward. I think, and for the residents, I think always I tell them to apply the Kidlin's law. So whenever you have a patient, rather than just writing down a diagnosis or prescription, I think write down the problem first. So what we are looking into, what are the problems, and they say Kidlin's law is that if you write down a problem, half of it is solved, because then we can apply our diagnostic reasoning skills to reach a diagnosis. I think. So always, even like the pathologist, and despite all investigations, we may face a problem, but we have to use our resources, teamwork, and follow the patient till we get the correct diagnosis. I think that was the crux, I think, in our patient. I thank you. And thank Dr. Shah and Dr. Lakshmi for giving us an opportunity to present this case in this forum.
Yeah, absolutely. So I must congratulate once again to the whole team, particularly Dr. Soham, for pursuing the diagnosis, and as as told by him, to take the biopsy at the final level, to take the opinion of senior. I think this happens day in and out. All centers are not very well equipped, but unless the clinician is satisfied with the diagnosis, and he or she should have a kind of clinical keenness to really find out what exactly is. If somebody says primarily on simple histopathology, this is normal, one should not. In fact, we have a tendency, we in our unit, we go to the pathologists, we sit down with histopathologists. Sometimes we look at the biopsy slide ourselves, and we try to discuss with them, because some of them, they don't know what exactly we are looking for. So feeding them with proper history, clinical findings really helps them to take further cuts, like in this case IHC or some other genetics and all those things. So I think in diagnostic problems, not in all cases. So we have to use our discretion and judgment, where in which case we have to go into all depths, and in which case you don't have to exercise all this because we have to be judgmental also, because all patients may not be really affording. That is another truth. So we have to balance between the two. And I really appreciate the way the discussion was done from the resident side by Tejaswini and particularly Dr. Mihir. And I remember one of my cases, Alzheimer's disease. He had presented with headache, papilledema, some sixth nerve palsy, then third nerve palsy. And then we had similar problem in diagnosis in histopathology also. Ultimately, by doing finer studies in histopathology, IHC, and further, classification, with the help of hematologists, we could label the patient with the proper diagnosis. So this is how neurology or medicine is, and Dr. Soham has very eloquently discussed some of the laws of medicine, which are always true, and we really want to pass on to the junior colleagues, because I can see that with the advent of more and more gadgets like CT, MR, these, that, clinical neurology is getting eroded. This is one of the reasons why we are conducting this long webinar series. As I said, this is 22nd of the episode, and we wish to continue as long as people show interest. Thank you once again, the team Karamsad from Swami Medical College, and over to my friend Dr. Lakshmi. Dr. Lakshmi.
My congratulations to the entire team. The presenter, I don't know how my pronunciation might be, I may pronounce their name wrongly, so forgive me about that. The first presenter was excellent. Dr. Tejaswini's discussion was excellent. All most of the references would be very useful for this, and the pictorial essay by Mihir was exceptional on the lytic lesions, which I thoroughly enjoyed. And as usual, Dr. Suram's Desoy's punch remarks of Hickham's dictum versus Occam's razor, and trying to put everything in. And the mastermind of this entire program, Professor Sudhir Shah, as usual, subtly pointed out the economic restraints of making the final diagnosis in most of the issues. Sometimes they get drained and come to us when we still want to do something more. They may not be willing. So with all this, thanks the entire team for their excellent effort and a wonderful case. And we will be meeting on the last Friday of next week with Dr. Vivek Nambiar and Dr. Professor Anand from Amrita Institute in Cochin will be discussing the case next month. Thank you. I hand it over to Dr. Arun Chadda for, I forgot his name, Arun Chadda. What is your name, presenter? What is your name? I just couldn't catch your name. Arshad?
Arun.
Huh?
Yes, sir.
Dr. Harshad is there.
Okay, fine. My thanks to you. Thank you. Bye-bye.
Thank you, sir. Thanks very much. Today, it's really great day that we are at the end of 22nd session of Secret of Neurology web series, which is the longest web series till date. And I, Arun Chadha, Associate Vice President, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 22 months. And I would like to thank our Honorable Course Director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And we are very thankful to the young neurologist, Dr. Harshad, for presenting such an excellent and unique case, and Dr. Tejaswini for further elaborating the case. And further to this, I would like to thank Dr. Mihir Parikh sir for presenting the case investigation and case analysis also. And thanks to Dr. Soham Desai sir, the HOD of Neurology in Shri Krishna Hospital Medical College, Karamsad, for providing the important learning points and the proceeding of this unique case. And once again, thank you all for your gracious presence. And I'm very sure the entire presentation will be extremely helpful and informative to all the participants. Thank you for participation, and I wish you all a very good night now with this month, and we are meeting again on 27th May 22 with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you very much. Thank you, sir.
You must say that we have archived all the webinars, and those who want to have access to them, they can write to us. Okay?
Definitely, sir. Definitely.
Okay.
Thank you, sir. Thank you, ma'am.
Thank you.
Thank you, sir.
Thank you, sir. Thank you very much.
Rohit, please end.